Welcome to the Valaura Exchange, where leaders connect the dots between health, humanity, and performance. Each episode brings real conversations, fresh perspectives, and the insights shaping the future of how healthcare leaders understand and solve today's most pressing challenges.
The Clover Health decision has generated a lot of conversation across the Medicare Advantage industry. And with that conversation has come a lot of uncertainty. Health plans are trying to understand what the ruling actually means today, what could change in the future, and perhaps more importantly, how they should make their decisions in the meantime. So rather than trying to predict exactly what CMS will do next, today we're going to focus on a more practical question. What should Medicare Advantage plans actually be doing while they wait for more clarity? Joining me today again is Jessica Muratore. Jessica has joined us on the podcast earlier this year, and I'm really excited to have her back and help us unpack this latest development and what it can mean for Medicare Advantage plans. Jessica, thanks again for joining me.
Thanks so much for having me, Theresa.
Of course. So I think first, just to kind of help us start from separating what we know and then what we don't know, the Clover decision has generated a lot of headlines and industry discussion. From your perspective, what do health plan leaders actually know today versus what remains uncertain?
Yeah, great place to start. I think the Clover decision undoubtedly changed the conversation around star ratings, but it did not change the fundamental mission of improving quality for members. What we know today is the ruling has raised important legal questions about CMS's authority in their ability to include certain measures and the process used to adopt them. We also know that CMS has appealed that decision, so the legal landscape is still evolving. From my perspective, the most important thing to do is separate what is changing from what is not. Health plans should avoid making strategic decisions based on speculation. What we do know is that HEDIS remains the foundation of clinical quality. Medication adherence and pharmacy quality continue to matter, and plans are still accountable for delivering high quality care and strong member experience. What does remain uncertain, though, is how this litigation will ultimately shape the long-term design of the STARS program. And we don't yet know whether higher courts will affirm or modify the decision, and or how CMS may respond through future rulemaking, or what the final composition of the Star Ratings program will look like over the next several years. What is certain, though, is health plans should not pause their quality strategies. Regardless of how the regulatory framework evolves, plans that invest in strong HEDIS performance and medication adherence, provider engagement, member experience, the cross-functional governance, they're going to be best positioned to succeed. So those capabilities we know and improve clinical outcomes and operational performance, whether they're tied to a specific STARS measure or not. So I think ultimately, Theresa, the plans that will come out ahead won't be the ones trying to predict the next court decision or CMS memo. They'll be the ones that have built or are building resilient quality organizations that can adapt quickly to whatever comes next.
Absolutely. No, I agree with you. And I think that distinction is important because plans still have decisions to make today. There's still a lot going on. There's still a lot they have to navigate in regards to just their normal day-to-day. But then, like you mentioned, still thinking ahead and having some substance to what they might think. Some things might be impacted when it comes to the litigation that we're still watching play out technically. So some organizations may wonder whether they should continue investing in Part D initiatives. I know that's a really big question I've been getting and hearing a lot, and I'm sure you've been getting that as well. What's your perspective, just given that I know a lot is still uncertain?
Yeah, as soon as that May 27th order was made public, I've been getting this question from vendors and health plans a lot, and understandably so. And I have so much to say on this topic. My perspective is that health plans should not confuse uncertainty around specific measures with uncertainty around quality itself. The Clover litigation has understandably caused health plans, organizations to question what the future of star ratings will look like, particularly for Part D. But CMS continues to publish the Part D star rating measure specifications and has finalized future technical enhancements, such as risk adjustment for the adherence measures. And we just got the technical specifications for STARS 27. And then this administration has also continued the implementation of the returning MTM, Comprehensive Medication Review, the CMR, STAR measure for applicable future STAR years. So these types of things suggest that CMS still views these as valid quality measures. The uncertainty is legal, not clinical. And we've seen that demonstrated by this administration and previous administrations, sorry. The Clover decision did not hold that medication adherence or these Part D measures are poor quality measures. So again, the uncertainty is from a legal perspective and not a clinical one. So what the court did conclude, though, is that CMS lacked that statutory authority to include certain measures, some of which is those Part D measures, under the current Medicare statute and the process CMS used. So these are very different issues. We know that this administration has appealed the Clover decision, while simultaneously issuing a limited recalculation back on June 17th for affected ratings. And CMS has also stated that that recalculation should not be interpreted as a definitive policy for future STAR ratings. So I would expect CMS to modify how those measures are legally incorporated in STAR ratings if the Clover decision ultimately stands. And there are several possible paths that they could take to do so. I think, though, when we talk about Part D and particularly those medication adherence measures, we know that they're supported by a tremendous amount of clinical evidence showing improvements in outcomes, reductions in healthcare costs, and CMS itself has cited these measures for years, and PQA's evidence base remains very strong. So even if the legal framework changes, plans that built strong medication management capabilities or are leveraging vendors to do so, or they're in the process of doing that, they are very unlikely to regret those investments.
No, I agree with you. And I think too, if you think about how Part D works, it is going to directly impact, like you mentioned, a lot of other measures and, well, obviously other healthcare measures that we're looking at, like readmissions, for example, or controlling just a patient's blood pressure, their A1C, et cetera. And that goes into our Part C side of the STAR measures, right? So I agree with you. That's how Valaura is positioning too. Like we're trying to track it closely, but we know that patients need that ongoing management. And once you slip, unfortunately, and aren't monitoring those patients, that's usually when, unfortunately, the outcomes can get worse for them too. So
Yeah.
completely fine with that response. But this actually brings up another important part of the conversation. Even though we're talking about individual measures or even specific parts of the STARS program, many of these quality strategies, they don't exist in isolation. So it kind of goes to what I just kind of stated. How do you see Part D performance influencing Part C outcomes and overall plan performance? I know you kind of built on that just initially already, but you wouldn't mind expanding a little bit more.
Yeah, I love having this conversation. I think it's so important. You and I talk about this frequently too. Part D and Part C STAR ratings measures, if we're just looking at it strictly from like the measure perspective, right? They're deeply interconnected. Medication adherence isn't just about improving Part D performance on STAR ratings. It has a direct impact on overall plan performance. Members who consistently take their medications are more likely to achieve blood pressure control, diabetes control, cholesterol management, which support HEDIS and other Part C quality outcomes. So, and we know strong medication management contributes to fewer avoidable hospitalizations, like you were saying, better chronic disease management, improved member experience, and overall lower total cost of care. So, we have tremendous amount of studies that show that higher performance on Part D medication adherence measures was associated with stronger performance on corresponding Part C clinical outcomes measures. Every year we see this trend. So I think this is an opportunity for plans to rethink the role of pharmacy if they haven't already. For years, many plans have viewed pharmacy quality primarily through the lens of Part D measures. But today, pharmacy should be viewed as an enterprise strategy. Pharmacy data can identify members who are struggling long before these issues appear in medical claims. It influences HEDIS performance and care transitions, chronic condition management, medication safety, the member experience as a whole, total cost of care, and frankly, ultimately, the overall health of the population.
And I'd like how you brought in the member experience part too, because it's not that we forget about it, but to be honest, there's so much going on a lot of the time where there's a lot of gaps that need to be closed. It's like, how do you also make sure that everything's coordinated, right? And you're getting as much as you can from the patient, but also supporting them as much as you can within those outreaches. You may not talk to them again sometimes, depending on how the engagement works. So the experience part is huge because I know that's also a big influence of the star measure ratings and whatnot. So thanks for adding that in too. And I know we talked a lot about what plans should be thinking under the system that we have today, but I think it's good to like maybe zoom out a little and think about where the program could go from here. So if CMS ultimately does decide to rebuild some portions of the star ratings program, what principles do you think should guide that change?
So I actually think that we're already seeing CMS rebuild the star ratings program, and that has been somewhat overshadowed by the Clover litigation. If you look at the 2027 final rule, CMS made some of the most significant structural changes to the program in years. They finalized the removal of 11 measures, largely administrative and process-oriented measures. They choose to retain measures that better reflect what they said, their words, clinical care outcomes and patient experience. And then we saw them add a new depression screening and follow-up measure to address an important gap that they called out, behavioral health. So CMS has been very explicit that it's streamlining and refocusing the measure set towards areas where quality differences are more meaningful to members. So I think those changes tell us quite a bit about CMS's broader direction, or at least with this administration. When you combine the final rule with commentary in the final rate announcement, MedPAC's longstanding recommendations, Universal Foundation, and recent CMS messaging, there are several themes that consistently emerge. And a lot of those are placing a greater emphasis on clinical outcomes over administrative processes, stronger focus on prevention and behavioral health, simplification of the methodology, and rewarding meaningful improvements in member health rather than compliance or check the box activities alone. So if that direction continues, I think there are, to get to your true question, right? Like there's several principles that should guide the future of star ratings. The first and the most obvious, continuing to prioritize measures with strong evidence that they're linked to improved clinical outcomes. I mean, CMS has been very clear on that. Also to encourage greater integration across Part C and Part D rather than treating them as separate programs. And I think you can actually even take that a step further now. I think you can add on top of that the integration of physical and behavioral health. We're going to see that on the Medicare Advantage side, but something that those of us on the Medicaid side of the house have been used to for over a decade. I also think that another principle would be rewarding plans for identifying risk early and proactively engaging members before their health deteriorates. This is where HOS truly comes into play, and it's one of the biggest reasons it's so hard too. And we know that this administration and previous administrations have been focused on and emphasized HOS. And then I think finally, and something that could be more exciting, is creating a methodology that's transparent and stable and predictable so plans can make longer term investments with confidence. I hope we're continuing to move away from the thinking about individual measures in isolation. The highest performing plans that I've worked for and worked with don't build separate strategies for HEDIS and Part D and HOS and CAPS. They build integrated quality strategies centered on the member. And when all these things naturally occur across multiple domains, that's where you see the greatest performance improvement. And I've spent over a decade working on the front lines at a health plan, and I know it's not as easy as I'm saying, but we don't have enough time to get into the how to make that happen. Maybe we could do that in another podcast, Theresa. I think ultimately, I don't think the future of star ratings is about adding more measures. It's about measuring the right things. And from my perspective, CMS has already started that transformation. The Clover litigation very well is influencing the legal framework and potentially methodology, but the broader policy direction towards fewer, more meaningful outcomes-focused measures is already well underway.
No, those are all really good points. I completely agree too, because it's one of those things where if you're able to hunker down, like you said, and even if it's not at all domains, but just trying your best to coordinate the best you can across all those domains, it just makes everything smoother and more calculated too. And what you mentioned about the proactive piece, I know that's huge. That's something that we really believe in as well. And when I was on the health plan side, something we tried to do as much as we could. I know it's a little more resource intensive sometimes just because you're adding not saying a new population, but you are adding more patients that will need your support to make sure that you're capturing their needs. But completely agree that it's really the best that we can do is making everything as coordinated as possible, breaking down those silos. And like you mentioned, there has been a lot of change already introduced by CMS. It's a great point. I never thought of it that way, but it is a little overshadowed right now just from the litigation standpoint. But I think everyone at their heart does know that that's the right thing for patients, or at least I hope so. So if not, they've learned that today, hopefully, from our conversation. But of course, I know the challenge for health plan leaders is that they can't wait until all these questions are resolved. There's too much going on. Like day to day, I know there's a load of things that they have to get done before making any investment decisions. So when the regulatory environment is evolving, how should Medicare Advantage organizations balance long-term investments with the short-term uncertainty like we've been talking about with this case?
Yeah, this is like, I feel like the $1 million question. I get asked this all the time by like, what should we do? What should we invest in? What should we focus on now? I think one of the biggest mistakes that plans can make during periods of uncertainty like this is allowing the uncertainty to become inactivity. And I don't think they intentionally do that, but this is what's happening. I've seen plans hesitate because they're waiting for the next final rule or the next court decision or the next piece of CMS guidance, or, I mean, honestly, even the end of the medical record review process to start prospective HEDIS activity that year. But when you truly understand Medicare Advantage, you understand it's a long-term business, and the capabilities that drive success take years and not months to build. So I think my advice is to distinguish between capabilities and regulations. The regulations will always continue to evolve, but capabilities like integrated data and predictive analytics, strong provider partnerships, care management, member engagement, enterprise governance, those are what create value regardless of how the star ratings methodology changes. And those are investments that improve quality and risk adjustment. They lower total cost of care, and they make organizations like health plans more agile when change inevitably comes. We know that change is inevitable in our industry. And we've actually seen this play out already, right? The Clover litigation has understandably captured the industry's attention, but at the same time, CMS has already begun reshaping the star ratings program through the 2027 final rule by removing the high-performing administrative measures. But like I said earlier, this has been so overshadowed by the Clover litigation. So these changes reinforce that organizations should continue investing in the fundamentals of quality rather than trying to react to every regulatory development. Because if they were, the removal of the administrative measures wouldn't sting so much because the clinical outcomes were going to be strong no matter what. I think, the organizations that will be most successful over the next 5-10 years won't necessarily be the ones that predict all the regulatory changes correctly. They'll be the ones that build capabilities that remain viable no matter what those changes are. And that's how you balance the long-term of investment with short-term uncertainty.
No, that's really helpful. And I think too, like you brought it up a few times, the coordination, the member experience, like if that's at the heart of what you're doing too, with all these campaigns that you have to orchestrate and execute, kind of helps keep things organized. And to your point, if things change, they're able to kind of plug and play, if you will, with whatever it is that alteration may be with a measure that they're expected to perform on, for example, because they're still at the heart of it, making sure that the patients are taken care of in the right way. So all great points. So thank you for adding those for us. And we're actually already to our last question. So to close this out, I know there's still a lot of the industry like watching and then waiting to understand like what's going on with this case. But plans have also continued they are trying to move forward. So as the industry continues watching the situation unfold, I guess what's one message you hope every Medicare Advantage leader takes away from today's discussion?
Oh, just one. I think my biggest message, and you've already heard it from me a couple times, do not let uncertainty become an excuse for standing still in inactivity. The star ratings program has always evolved and it will continue to evolve. We've seen methodology changes, new measures, measures removed, measures modified, changes in weighting, legal challenges, shifting priorities, policy priorities, right? That is part of the environment we operate in. What doesn't change is the importance of delivering that high quality care to members, which is ultimately the intent of why the star ratings program exists. So whether the measures are HEDIS measures or pharmacy measures or CAPS or HOS, the plans that are consistently performing well are the ones that continue to build strong clinical partnerships, and they're integrated with pharmacy and population health. They invest in data and predictive analytics, and they create a culture where quality is everyone's responsibility and it's not just the quality department. I like to ask health plan leaders this question when I start working with them. What capabilities do we need regardless of what the measure set looks like? If you take a step back and you build an organization with integrated data, strong provider partnerships, effective medication management, and those predictive analytics, enterprise-wide accountability for quality, you'll be well positioned no matter how the program evolves. And don't feel like you have to build it all overnight. I mean, that's not realistic. The highest performing plans didn't become high performing plans in a single year. They built those capabilities one step at a time, making continuous improvements and staying committed to the long game. And we see that every year when CMS releases that fact sheet about like the performance and the time that the contracts have been in the market. The more mature plans, the more mature contracts, the ones that have been around longer perform higher. And so I don't know, it makes me think of like the Rome wasn't built in a day and neither was a 5-star health plan. So I've always believed that star ratings are not the goal, that they're the result. Because before I entered quality, I worked in multiple different departments around the health plan. And so star ratings are the result of a well-run health plan that consistently is delivering better care and better experiences and better outcomes for its members. And I did have the distinct pleasure of working at a 5-star health plan, and I saw this in action. And I was trained to think this way so early on in my managed care career that I'm very grateful for that. But I know regulations will change and measures will come and go. But if you stay focused on those things, you will be well positioned for whatever comes next.
I agree with that. I think too, like how you hinted to or pointed out the continuous improvement, that's also huge. So you can build something, but we all know that there's going to need to be tweaks or changes as it's actually been running in real life. Because I mean, not everything that you can conceptualize in a PRD or whatever it is to put that out there is going to be perfect when it's released or launched. And like you said, it's persistence, like keeping at it and making sure that you're learning from your membership too, right? Making sure you know them, your patients, that's going to come and go and change too. So every year there's a new challenge, a new tackle, but I like the idea of basically sticking to that infrastructure. Like that's key because that should help then produce the star ratings that everyone's trying to aim, which is ideally 4 or higher. So that was really great. Thank you so much for coming and joining us today and having the time to do another podcast. Actually, kind of thought it was nice, tied nicely with how you talked about the final rule and rate announcement earlier this year. And like you mentioned, maybe we can do another one to kind of build off of all the other capabilities that we can chat about for Medicare Advantage organizations. But one other question, like just a low pressure one, but since we have so much going on with the litigation, are there any like reliable sources or anything you would want to point the audience to just to help them continue to be informed about the Clover litigation, just to keep track of it and have a better streamlined way of monitoring the news?
Yeah, I mean, I think ultimately there's a lot of, experts in our industry that do really great jobs of posting blogs and information out on LinkedIn. So, very free resources. I would say going out there and looking for some of those, star rating expert resources. And also, some of the biggest learning opportunities, and I know people are going to cringe, is going out and actually reading these complaints, going out and reading these orders and like seeing what is actually being argued. I think, these lawsuits have these complaints that have to establish like what the star ratings program is and how the methodology is applied and all this stuff. And you can learn a lot just from reading that. If you have ever read like the technical notes, you can learn from that. But then going in and reading the actual legal documents, yes, there's a lot of legalese, and yes, it can become pretty burdensome. But reading components of that, I think has been very helpful for a lot of people to understand what these true arguments are, and the transcripts that are coming out too, like what the conversations are between CMS and the plaintiffs and the courts and what these judges are saying. So I would also recommend like do your homework and go straight to the source.
I like that. No, it's a really good idea. And I think, like you said, it just helps them familiarize themselves with what actually is being said instead of seeing it regurgitated, sometimes not in the wrong way, just maybe a little differently
Yeah.
than it played out. So those are really good tips. Thank you so much. And just
Yeah.
taking the time to speak with us today. So again, I really love having you on. I wanted to thank all of our audience for just taking the time to watch us. And we'll definitely be back soon. And I'm sure we'll be chatting again, Jessica, for another episode. But thank you again, and I hope everyone has a great day.
Thank you.